Welcome to Laerdal's booth at the National Patient Safety Foundation Congress 2015 being held at the JW Marriott this week in Austin, Texas. We are surrounded by 1,000 visitors, all representing hospitals from across the country, members representing continuous quality improvement, risk management, chief medical officers, chief nursing officers, and a host of others representing healthcare throughout our hospital system. We're joined this morning by Roxanne Gardner. Roxanne, welcome. Roxanne Gardner is from the Center for Medical Simulation in Boston, Massachusetts, and you are the director of the L&D program, the Labor and Delivery program.
Yes.
For the center. So tell us a little bit about yourself, Roxanne, and about your background and what you do.
Okay. Well, I'm an obstetrician gynecologist by professional training. I did my training in Boston, went to medical school, did my residency at Beth Israel Deaconess, and then went on to practice. I did some community health center work for quite a long period of time. Ended up at the Brigham. And when I went to the Brigham, unfortunately for me, I had a medical event happen to me, which sort of shifted my career. And out of that came a very great passion for patient safety generally. And I had the great fortune of being acquainted with Jeff Cooper. And so I fell in love with simulation. He had me at hello, basically. And it was so amazing to me. I never knew that simulation existed in healthcare until that time, but it had been happening for anesthesiologists and residents in anesthesia for almost 10 years by that time. So I felt sort of cheated by not having had that opportunity when I was at Beth Israel or my short stay at the Brigham before I ended up in my medical situation. But I ended up going into simulation-based education. So I'm a simulation-based educator. Because of my great fortune to meet Jeff Cooper at that point in time, I was involved in a project that was sponsored by CRICO, our malpractice risk management insurer for the Harvard-affiliated medical hospitals. And what they wanted to do was to have the Center for Medical Simulation create a simulation-based training program for teamwork and communication for labor and delivery clinicians. And their focus was really on training obstetricians because they're the ones that are named most in medical malpractice suits.
Sure.
So residents were also part of the picture, but the rate at which they're involved in a case, in a suit, is much less than, of course, the attendings and our midwives and our nurses as well. So, so that was the focus of how we had to direct the program development. And so my colleague, Tony Walzer, who is actually co-director with me of the program, we were just fortunate enough to be at the ground level of this particular project. We had the time and we had the initiative and the urgency with which to create the program. And so together with my colleagues at Center for Medical Simulation, we created a labor and delivery program that really modeled itself after what the anesthesia program had been developed as. But unlike anesthesia, the anesthesia program was very siloed. So anesthesiologists, whether they were faculty or residents, would come together to train just themselves, and they would the scenarios would use standardized characters and patients to play the various roles that comprise a hospital team.
Sure.
And Tony and I, when we were discussing, what would make a good approach, we felt that an interprofessional approach was the most appropriate. We wanted all members that represented the perinatal team to be involved in this type of training, because y'all need to be on the same page, and we often depend on a number of individuals in providing the safest care we can to our patients. So that's sort of the genesis of how I got to where I got to. And we had the great fortune of working alongside our risk managers in the CRICO team that helped support our endeavors. And in 2004, I actually was asked by Luke Sato, who's our vice president for patient safety at CRICO, to be the obstetrical consultant and to provide greater advice and program development and implementation for patient safety programs for obstetricians. So I was involved in that for 10 years alongside all the educational activity. And I did keep a clinical piece to my puzzle. So I continue to see patients. I deliver mannequin babies, and I see adolescent gynecology patients, so teenagers.
Sure.
So it's a lot of fun. It's a great mix. I think at the beginning of my career, I would never have thought that I would be doing this sort of mix at this point, but it's just wonderful.
That's a fantastic story.
Yeah.
From a labor and delivery perspective, what do you see as the biggest obstacle in healthcare to improving patient safety? I mean, there's some incredible statistics out there. 9% of all births being associated with some form of adverse event. We have OBGYNs being sued at a rate of typically 2.5 times within their career. We have hospitals having to self-insure because of the high rates. And 45% of all malpractice suits exceeding $5 million are labor and delivery related. So what is the obstacle from your perspective in improving perinatal patient safety?
It's a very good question, and I don't think that there's one magic bullet that I could say, you know, if you invested all your money here, you'd be able to make the fix. I think, like some of the plenary commentary that we heard this morning, culture plays such a great role in your ability to feel that you can respect each other in your coworkers, that you have the comfort by which to speak up if you know something or hear something, or whether you're a resident or a medical student or a nurse or a nursing student or midwife, anesthesiologist, etc. I think that plays a lot into, you know, your ability to trap an error before it becomes an adverse event. I think teamwork and communication continue to be skills that we need to cultivate. And I really liked what was spoken about this morning, which was the idea of respect, and not thinking of it as just respect for patients, but respect for each other, and realizing that we're all under the pressure of time, and maybe just being a little bit more patient, or being a little bit more willing to say, hey, you know, I see you're a little bit stressed, and it looks like you've got a lot of things on your plate. Is there anything I can do to help? You know, and just having that collegiality, I think, would go a long way towards being able to say, you know what, I would like it if you could just do me this favor, and to feel like you could be reciprocated. And that when you're under a time of stress, somebody would recognize you and have your back. So, and then I think another part of it is expectations, patient expectations. And I think in the world of obstetrics, what parent, what couple, what mother, what grandmother, what sister wouldn't want to have the perfect baby come out of this particular birthing situation? And unfortunately, events do happen. And we try as human beings to be able to intervene, to think about what could possibly be causing this particular situation, and to develop the proper approach and therapeutic modality to intervene successfully. And sometimes we miss the mark. So in addition to the expectations of patients and of ourselves, there's also clinical decision making. And I think one of the things that CRICO is really addressing now, they've done a lot of work with anesthesia-related events and obstetrics-related events, and they're really looking deeper into diagnostic error and problem solving. So some of our advanced labor and delivery courses, we really focus in on what are those modalities of diagnostic problem solving and clinical decision making in the moment of pressure and urgency. And what can we do to help you get it right? You know. But then again, you just are humbled by the fact that sometimes you do everything you can, you do get the right diagnosis, but there's such an acuity in the severity of the particular disorder that it was inevitable that something untoward was going to happen. And that's really the sad part.
Sure, of course. Now, how is simulation being used to address some of those high pressure, minimal time moments where you have to make a split decision clinically? How are you using simulation? Or maybe if you'd like, you can talk about how you're using simulation here.
Oh, well, okay. Well, I think one of the fun things about being a simulation-based educator and having such a great group of people to pull from in my team who work at the Center for Medical Simulation is that we really can sit down and craft a scenario that's based on a claims experience or based on a series of adverse events that we've seen in the various hospitals around, whether it's a community-based hospital or an academic tertiary care center. Oftentimes the events can be quite similar, but maybe a little bit different variation of it. And we can bring that particular case to life so that when our clinicians come in to experience it, either those who say, oh, that can't possibly happen, we have the ability to say, well, it is based on our real case that has happened,
sure,
or a series of cases that have happened. So for instance, we've had situations where a woman has tried to deliver vaginally, and she has pushed and pushed and pushed. She's been in the second stage of labor for quite a long time, and she just can't get that baby out. But she's managed to get the baby down low enough in the pelvis that it's really socked in low. And the decision may be made to do a cesarean section. It may be made urgently because the fetal heart rate tracing has deteriorated, or it may be that the baby's really okay, but you're not getting anywhere, so you've got to deliver her. So cesarean is the only way to go.
Sure.
And so we have a situation where now the patient is brought into the operating room, and they've made the uterine incision, and they can't get the baby out because it's wedged. The head is actually wedged in. And so there are some techniques that you can do that eerily are reminiscent of some of the algorithmic approaches to shoulder dystocia. So you can actually recreate that situation because they do happen commonly, but they don't happen enough that
for you to really be on your game.
Right, exactly.
Sure.
So that was a really great case where you're under some pressure of time, maybe not as severe as with the case of shoulder dystocia, but still it can be quite challenging, and you want to get that baby out quickly. And it's very easy to lose track of time. So by doing this case,
isn't that interesting? Yep.
We can, talk about it. We can look at the videotape afterwards and try to understand ways that we did what we did that was right, and what are ways that we could do to improve it and do it better. And in simulation, in that particular case, we actually take the team back and do the same case over again.
Nice.
We may change.
Deliberate practice.
Yeah, so it's deliberate practice. Yep. And we tell them, at the end of the case, okay, this case is over, and what we're going to be doing next is we're going to be doing this exact same case again.
Sure.
And we're going to have different people. You can decide who's going to take on what role, and we're going to start it a little bit later in the case, so you're going to go straight to the heart of the matter and take it from there. And it's really, quite a rewarding experience.
That's nice.
And sometimes I've had some of my clinicians come back to me, because they're my colleagues, I live with them, and they'll come back to me and they'll say, oh my God, I worry every time I come to the Sim Center, because whenever I have a case there, within like a week or two, I have that case in real life. And so that was the experience that I had recently with this particular wedged head case.
Now, I was going to ask what your favorite patient safety success story is, but maybe that would be it. But do you have another that comes to mind that you just want to talk about?
So in that same course where we have the wedged head, the other topic that we have focused in on is early sepsis. What are the techniques that you can employ to recognize sepsis early on? And then what are the techniques that you can employ to intervene and prevent that deterioration to septic shock?
Sure.
So the early sepsis campaign. And so we have a case where a patient is, she's delivered already, so she's postpartum. And the team has to come in and evaluate her and figure out, what's going on, and then properly treat her. And so then we sit down, we debrief and go through the videotape, and we talk about early sepsis and what are the warning signs and that sort of thing. And so this particular clinician happened to come back for her next advanced course, and we run them through every 2 years now. So she came in. She was actually from a community hospital. She wasn't a CRICO-insured provider. She was working for a hospital system that had a private malpractice coverage. And the first thing she said during the orientation, because we talk about, we provide time to reflect. So, any events have happened that, based on your experience before, came to bear in mind, and did any of the things that you learned before have an impact on anything that you experienced since? And so this person just couldn't wait to raise her hand and say, I just want to let you know that because of that sepsis case, I was able to recognize that this patient was going downhill and I needed to intervene, whereas otherwise I would have just said, we'll just check her again in another hour or so. And I realized that if I had let that happen and let that hour pass, I would have lost that opportunity to save her. And it was like really touching.
That's wonderful.
Really touching.
That's having an impact on helping save lives.
Yeah.
So we're being viewed by potentially thousands of hospitals across the country. Mm-hmm. Shoveling all the snow you've had to shovel in Boston this year is probably a lot more stressful than that. What words of wisdom would you have for anybody viewing? For anyone going into simulation, especially in the world of labor and delivery, what would be your advice to somebody that's just getting into simulation, just starting to use it to impact change?
Okay. Well, first I would take a step back, and for those people who aren't considering it, I would say don't wait for an adverse event to happen. Take the initiative, look at your history of situations, your pebbles in your shoe, the things that are constantly bothering you. Ask your clinicians, go around the table and say, what are the things that keep you up at night? And try to gather what are those systems issues, what are those clinical issues that keep coming up as themes, and start thinking about ways that you could address that by simulation. Simulation isn't the end-all and be-all, but I do think it's a valuable technique, and it really is. It aligns itself well with adult learning theory. So, but if you're undertaking simulation and wanting to develop a program, I think the leadership really needs to provide support. Leadership begins at the top, and I think that they need to take it seriously. And it's going to take a certain amount of investment, and the return on investment may be a little bit difficult and challenging to determine. So if you look at and identify metrics early on, you may be able to get a better handle on some of those savings because you've taken the time to figure out, okay, what are we going to monitor going forward? What are the number of term babies, singleton births, no congenital anomalies that have a low APGAR, less than 4. Of course. How many of those are being born now, and how many are being born in whatever number of years that you want to track it, or over time.
Sure.
And then I think another way to develop a metric is to survey your staff, so doing a culture survey and following culture survey data to see if that has an impact from your teamwork and communication training. I think space and location is a really big issue. Some programs are very mobile, and so they do mobile in situ simulation.
Nice.
And there are some things to think about with in situ. You don't want to leave fake medications behind. There are some safety concerns to be mindful of. So you need to take in situ seriously. If you have a simulation laboratory or a sim center that's around your hospital campus, sometimes it's nice to take people out of that high test environment and bring them over to sort of a zone of safety where they can deliberately practice and reflect and share experiences and learn from each other. So there's a lot of different ways to sort of do simulation, and I think that there's no one right or wrong way in terms of, this is the best location, or, this many number of hours. We don't have any data that shows us that, doing a 4-hour block of simulation is better or worse than a 7-hour block, and, or over the course of 1 day or 3 days. There's some studies that have been done looking at, the interval of time that goes by, and it seems that those folks that maybe don't perform well under pressure or for whatever other reason, their skill set is a little bit subpar, maybe they need to go through more frequent trainings compared to those that are much more skillful, let's say. And maybe they need every 2 years or 3-year refresher. But I think in the aviation industry, there's a lot of lessons learned. And
sure,
pilots go through trainings on a yearly basis. They stand down, they take the time off, and there's some very specific tasks that they need to be put through to train for those high acuity, low frequency events like landing on the Hudson.
And thank goodness they do. Thank goodness they do. You have given us a fabulous education. We really appreciate it, Roxanne. That's Roxanne Gardner from the Center for Medical Simulation in Boston, Massachusetts. Please join us in a few minutes for our next guest. Roxanne, thank you very much.
Thank you very much.